Thank you, Dr. Renke and Dr. Muazzam, and good afternoon, all members and guests. So I have no disclosures, but I would like to thank the SAGES organization, as this research was funded in part by a SAGES 2023 Medical Student Summer Research Award. The Stop-It randomized control trial pioneered limiting excessive antibiotics to patients with intra-abdominal infections and adequate surgical source control. Stop-It primary endpoints had a composite of intra-abdominal infections, surgical site infections, and death within 30 days, and this was termed failure. Stop-It tested failure 4 days versus standard of care differences, not equivalence. And the NIH ended funding for futility with half the predetermined statistical sample size enrolled, and they concluded similarity. 4-day standard of care equivalence was not established. And if we look back in the literature, it really has no consensus regarding best primary endpoints in randomized controlled trials of intra-abdominal infections. So our objective was to identify possible significant treatment effects 4 days versus standard of care in intra-abdominal infections after adequate surgical source control and independent variables affecting outcomes. So our methods. We took data from 518 patients enrolled in the Stop-It randomized controlled trial, and we analyzed them retrospectively in 2 groups, 4 days in standard of care and also separately as one group. Pre-randomization variables were analyzed by SMART methodology to predict composite endpoint failure using stepwise selection in logistic regression models for 4 days and standard of care groups. Separate analyses use multivariate regression analysis and chi-squared with a simple Cohen-Kappa coefficient. All pre-randomization clinical data points were tested as possible weighted independent variables. No pre-randomization variable predicted failure in 4 days. And pre-randomization Apache 2 predicted failure in standard of care, but no significant cut point determined treatment effect, and our area under the curve was 0.608. So the data did not support SMART modeling for 4 days versus standard of care differences. Endpoints for intra-abdominal infections studies should at least agree moderately with hospital discharge if they are associated clinically with patient pathophysiology. Published guidelines for intra-abdominal infection endpoints include mortality and those listed here. Death in Stop-It was too infrequent to analyze. There was only 5 deaths. So we compared failure with success in hospital discharge at 7, 14, and 21 days. So there should be at least moderate agreement between failure and days in the hospital. And accompanying Cohen's kappa should be above 0.61, and as we see in the table here, it's below that. Cohen's kappa values here reflect a weak agreement between hospital days and failure, and hospitalization and failure do not agree enough to warrant using failure as replacement for hospital days. And our number of discordant values here, that's the discordant patients at 7, 14, and 21 days, and it's a pretty significant number since there was 518 patients in the study. So here we're seeing the association of pre-randomization variables in Stop-It with hospital discharge. And we're seeing significant associations at 7, 14, and 21 days with extra-abdominal infection, Apache 2, age, and maximum white blood cells. Of note, there is a significant association with failure in Apache 2 only, and not with failure with any other pre-randomization variables. So no pre-randomization variable predicted the composite definition of failure in Stop-It 4-day patients, and only Apache 2 predicted standard of care failure. Low Cohen-Kappa values indicated that failure did not agree at least moderately with hospitalization discharge at 7, 14, or 21 days. So failure does not reflect hospitalization. Other well-known pre-randomization independent variables which affect outcomes did not predict failure, and is further evidence of failure not representing patient outcomes. Failure was not a clinically reliable endpoint in intra-abdominal infections for evaluating patient outcomes. So equivalence is determined if the upper and lower 90% confidence interval estimates for the difference between 2 treatments fall within predefined and clinically relevant equivalence margins. Ensuring adequate sample sizes is paramount for achieving sufficient statistical power for randomized controlled trials in intra-abdominal infections. sufficient sample sizes, reduce risks of erroneously concluding equivalence when intertreatment differences may exist, and of type 1 errors. Conversely, inadequate sample sizes can lead to inconclusive results, as seen in STOP-IT, or incorrect conclusions. Careful planning in sample size determination and collecting the calculated number of subjects is crucial to success in randomized controlled trials. The NIH, other government sponsors of randomized controlled trials, and the pharmaceutical industry must support approved studies through the predetermined sample sizes for equivalence. The STOP-IT sample size was based on failure, which does not adequately agree, based on our Cohen's kappa, with time in the hospital to be a measure of patient outcomes. Results identify no evidence to suggest that 4 days is an adequate replacement for standard of care with respect to patient outcomes. Randomized controlled trials in intra-abdominal infections should consider these findings and search for prospectively validated, clinically reliable endpoints that agree consistently with hospitalization and secure adequate sample sizes. Thank you, all guests and members.